when we're looking at taking care of our knees, it's actually taking care of our hips and our ankles. And looking at these risk factors, they're hip and ankle and foot risk factors that then transition into knee pain. Knee pain is very rarely ever the knee's fault. It usually just gets the symptoms and the problems dumped on it from the feet and the ankles and from the hip.
Welcome to the Joint Pain Podcast, where we have discussions on the science and art of joint pain and longevity. I'm your host, Matthew Lister, the founder of Align Pain Management. I am here with my lovely wife, Jaylee Lister, the head of outcomes at Align, and today we're going to be talking about preventing knee replacements. We're going to be talking about the startling statistics on the rise of the total knee replacement, and we're going to be talking about the 5 major risk factors and all of the lifestyle practices that you can put in place to prevent knee replacements. So I'd like to start with some statistics to give the viewers some context for the scope of the problem. According to the NIH, in 2000, there were 188,000 knee replacement surgeries done. In 2023, there was over 800,000 knee replacement surgeries done in the U.S. That number has increased by over 400% in the last 20 years, and the most notable increase is happening in the ages of 45 to 64. And the research has shown that the increase can't be largely attributed to the obesity epidemic. And so the reason that I think that that is interesting is we're seeing this dramatic exponential increase in knee replacement surgeries happening in osteoarthritis of the knee. And it's happening to the U.S. Population at a younger and younger age. I know in our line of work, we see this happening down into people's 40s, and nobody was expecting a knee replacement surgery in their 40s. And so I would like to talk about what are the risk factors that people need to be thinking about and managing in order to prevent knee replacements. Let's start by defining this. Do you want to tell people what is a knee replacement?
So a knee replacement is when you have no more cartilage left in between your bones of your knee, so in between your femur and in between your tibia. There's no more cartilage there, and so your bone is actually touching the other bone. So a knee replacement is when they go in surgically and repair that joint and replace it with metal.
And the purpose of the knee replacement is to correct the effects of osteoarthritis. Osteoarthritis is thrown around a lot. I think a lot of people don't even understand what osteoarthritis is. Do you want to clear that up for people?
Yeah, so osteoarthritis is, again, like I just said, it's where you don't have enough cartilage in between the bones of your knee any longer. So what that leads to is inflammation in that joint. So when those bones touch, there's something wrong, your body sends a pain signal, and it can be really, really painful to not have cartilage in between your bones. That's what's creating cushion, so that when you're walking or running or doing your daily life, your bones aren't touching each other. They're not supposed to touch each other. And so osteoarthritis is that inflammation of not having cartilage. That's different than something like rheumatoid arthritis, where that's an autoimmune disorder.
Great. So I'd like to start to unpack the drivers and risk factors of osteoarthritis and the need to get knee replacements. There are 5. So when we think about risk factors for osteoarthritis and needing a knee replacement, there are 5 big ones that stand out. And I'd like to just sort of list them and then go through and unpack them one by one. The first one is genetics. The second one is the neuroanatomy of the knee, and we'll explain what that is. The third one is biomechanics, how your joints are working. The fourth one is joint load dosage. How much load are you giving to your knees in a given week? And then the last one is body weight, which is a variable. So I'd love to dive in and just start unpacking these things. Let's start with genetics. You want to take this one or you want me to?
You can.
Okay. So estimates from an NIH study estimated heritability of knee replacements and osteoarthritis in the knee at 30 to 35%. And so that means that 30 to 35% of the equation of getting osteoarthritis and needing a knee replacement is genetics. And now I think that I think it's really easy for people to hear that and go, oh no, because my parents had a knee replacement, I'm going to have to get a knee replacement. I think that 30 to 35% genetic component is actually hugely hopeful. It means that there is the vast majority of the equation is manageable risk factors and lifestyle variables that you can control. And so the biggest piece of the pie are things that are happening in our day-to-day lives that we can manage, that we can proactively control to put us on another track. Because just because our genes are leaning a certain way, pushing us a certain way, doesn't mean that that has to express itself, especially with a number as low as 30 to 35%.
Totally. And you can have the same genes as other people in your family, but the way that you manage and take care of your body can be vastly different than the people in your family. And so knowing that your genes are your genes, but you have a lot of control about your lifestyle, of your nutrition, of the way that you move your body and take care of your joints. And like you said, most of it is under control.
Yeah, 65 to 70% is nothing to sneeze at.
Yeah.
Moving on, neuroanatomy. So the cartilage in the knee, which is what is lost when you have osteoarthritis and need a knee replacement. The reason that the neuroanatomy is such a risk factor is because the cartilage in the knee is aneural and avascular. And what that means is that there are no pain receptors in the cartilage, and there is very little blood supply in the cartilage. So what are the practical implications of that? It means you can be grinding down the cartilage in your knee through faulty biomechanics, through overdoing or underdoing loading on the knees, and you can be rapidly damaging your cartilage. But because there's no pain receptors in the cartilage of the knee, you don't get any pain signals. And so there's no early warning signal that you're destroying the cartilage in your knee. And it is avascular, which means there is very little blood supply in the cartilage of the knee. And so once it's gone, it's gone. There's not really a lot that you can do to regrow the cartilage in the knee. And so we don't even get a pain signal until the bones touch. And then we don't really have an opportunity to regrow that in any substantial manner. And so a knee replacement is sort of all we're left with. And so we have a very late warning signal, and we don't have any means of altering that once that signal is given.
Totally. And I think that some people with osteoarthritis in their knee, if it's really bad, they're like, I want to fix this without surgery. I want to try and, optimize the situation. And you can definitely optimize it as much as you can control. But the reality is that the structural damage is already there. And like you said, we can't really do a good job of growing back cartilage at a rate that is practical for that person's life. And so in that situation, a knee replacement is the best answer. And so even if people are really wanting to avoid knee replacements, if you already have really severe osteoarthritis, you need, and it's been there long enough, you need to get a knee replacement. And so I think in that regards, it's not always avoiding surgery. It's just getting the surgery when it's necessary. Now, if you have had an MRI for another reason and you know that your meniscus or the cartilage is slowly deteriorating, then you know that you can step into prevention mode. And or if you don't have knee pain or do have knee pain, start fixing it now. Don't let it get to the point where there is osteoarthritis and then you have to get a knee replacement.
Yeah, I think I think the take-home message for this particular risk factor is don't wait until 3 years before you need a knee replacement to start thinking about prevention. By that point, it's likely too late. Prevention needs to be thought about 10 years, 20 years beforehand, and just having a high value for health.
Yeah, I mean, prevention comes before there's pain or when there's very small amounts of pain. If you're dealing with IT band syndrome, that is a sign that something is not right in your knee and something needs to get fixed. Now, if you ignore that IT band syndrome and you just keep pushing through life and pushing through whatever it is that you need to do, then that's going to lead to more degeneration in the knee. That's going to lead to osteoarthritis, and that's going to lead to a knee replacement.
Yeah, I think having a high value for taking care of your knees, taking care of your joints, getting annual checkups on how are my joints functioning? Are they functioning well or poorly? That's the type of mindset that helps people prevent knee replacements. And just that risk factor of just the inherent anatomy of that cartilage is super important for people to understand. Okay, let's move to biomechanics. Let's lay down a high-level principle, and then we can talk about some individual risk factors inside of biomechanics. Any biomechanical condition that creates misalignments in the knee, misalignments that can be torsionally, rotations between the tibia and the femur. It can also just be misalignment, sort of bow-legged or knock-kneed, valgum, valgus. Any misalignments of the knee are going to rapidly move you toward degenerating the cartilage between the knee. So there are three main causes for knee misalignments. Let's just start to unpack those. The first one that we talk about is glute medius weakness. You want to take this one?
Yeah, I think too, before talking about glute medius weakness, the knee is just a hinge joint, and so it should just have to hinge back and forth. Sure, there's small amounts of torsion that happen in that knee, but that knee should just rock back and forth. It is between two hypermobile joints, your hip and your ankle. And so your knee sits between these two joints that need to have the mobility so that the knee doesn't have to have the mobility. And the ankle and the hip have to stay really, really stable and really strong to support the knee well. And so when we're looking at these risk factors, none of them are actually inside of the knee itself. They're all above and below the knee. And so I think that's really, really important to understand that your ankles and your feet are mobility joints and they need to be stable and strong. Your knee is a stability joint. It should just have to hinge back and forth. And your hip is a mobility joint that needs to be really stable and strong as well. And every muscle that's connected inside of the knee is also connected into the feet and the ankles or up into the hip. And so when we're looking at taking care of our knees, it's actually taking care of our hips and our ankles. And looking at these risk factors, they're hip and ankle and foot risk factors that then transition into knee pain. And so knee pain is very rarely ever the knee's fault. It usually just gets the symptoms and the problems dumped on it from the feet and the ankles and from the hip. So glute medius weakness is a weakness through your glute medius muscle, which lays on the outside of your hip. It is a very important muscle to keep stable and strong because it's responsible for lateral hip stability. So what that means is, like, when you're walking, your glute medius needs to stay stable and strong to support your body weight on one leg all the way until you transition into that other leg. And that's even exponentially increased the need of strength and stability in the glute medius from walking to running. And so if you're wanting to run or you're having knee pain when you're running, your glute medius is too weak for running. You need to strengthen your glute medius. And so that lateral hip stability is so, so important, because if you don't have lateral hip stability, what happens when you take a step? Your hip collapses and your knee jets inward. And so that misalignment in the knee every step you're taking because of glute medius weakness is increasing the load placed on that knee, and then that increases the degeneration of the cartilage.
Yeah, and I think the other part of that is when the glute medius gets weak, the TFL has to work harder because that's the other lateral pelvic stabilizer. So when the glute medius gets weak, the TFL muscle on the front outside of the hip has to work harder. Well, the TFL inserts into the IT band, and the IT band runs all the way down to the tibia, down below the knee, and it creates this rotation through the knee. So whenever we get a weak glute medius, the TFL works harder, and that actually creates through a chain of connective tissue a rotation and a torsion through the knee that is really detrimental to long-term knee health.
I think two life examples of this are, we talked about running, but also when you're walking downhill. If you get really bad IT band pain or knee pain when you're walking downhill, your TFL is too tight. It's taking the brunt of the hip stability because your glute medius is weak. The IT band is getting tight because your TFL is tight, and that's putting pressure through your knees. And so if you have an early warning sign of IT band pain or pain in your knees walking up or down stairs, that is a sure sign that you need to fix some biomechanics so that that doesn't continue down the road.
Where would somebody, just to clarify for people who may not know what an IT band is, where would someone feel IT band syndrome?
Yeah. So IT bands get flared on the lateral side of the knee, but that pain can also radiate into the knee slightly and then also down past the knee. So on the lateral aspect of your knee, just above your calf, is also a symptomatic spot.
Let's talk lifestyle practices for maintaining a strong glute medius. So we'll add a video of this exercise in the show notes, but it is an outer thigh raise. Lying on your side, keeping your legs slightly behind you, raising and lowering. Check out the video, but basically you need to be able to have a really strong lateral hip. Video explainer in the show notes. So the second big risk factor biomechanically is a big toe that is too rigid, that won't extend backwards to a full 60 to 90 degrees, or a big toe that is misaligned, sort of diving under toward the other toes, and just weakness through that big toe or the arch of the foot.
I think a good way to see if you have adequate big toe mobility is seated. Keep your foot on the ground and pull your big toe back up as far as it can go. And if your big toe is not facing towards the ceiling, more or less, your big toe is not moving as much as it should. The big toe just gets so forgotten. We put on our shoes and we forget about our feet, but our feet are joints too, and they're the foundation of our body. And so if our foundation is not functional and healthy and mobile, stable, and strong, that dysfunction in those joints is going to get passed to the next joint. And what's the next joint? The ankle. And then that's going to get passed to the knee. And so when we have a dysfunctional big toe, it goes untreated for a long time, it's going to cause the more long-term effects.
So the big toe should be able to extend, go into extension 60 to 90 degrees. It also shouldn't adduct and like the toes be squished, go into adduction. The big toe should be splayed outward from the midline of the foot. How does this damage the knee biomechanically?
So it goes back to gait cycle, how we walk. When we take a step, we should be able to push through our big toe fully so that our big toe is in that full extended position. And we're pushing off. The last thing we use to push off the ground until we take our next step is our big toe. But if our big toe is squished into our other toes and it doesn't even have the mobility to go bend backwards, we end up pushing through the inside of our foot. Now, what that causes, again, is a lack of mobility through the feet. So where does that mobility requirement go? It goes up into the knee. And so the knee then again collapses in because it's compensating for the lack of mobility of that big toe. And so it causes torsion again in the knee that over time, if every single step you're taking has a misalignment in your knee because your big toe isn't functioning, that knee is going to have an increased rate of degeneration, and then you end up with osteoarthritis earlier in life because your big toe isn't functioning well.
Yep. So let's talk about lifestyle practices for the big toe, the feet, and then let's talk footwear. Lifestyle practices to maintain a healthy big toe. Big toe mobilizations, really simple. You just grab the foot, take the big toe, bend it backwards, forwards, take it through flexion and extension, its full range of motion. And again, that big toe should extend backwards 60 to 90 degrees. And we're going to put a link to a video of that in the show notes. Another exercise that should be just a weekly staple is banded toe presses. Fighting against the resistance of a band, keeping the base of your big toe down on the floor, pushing that band down and strengthening that abductor hallucis muscle that stabilizes the big toe. Again, we'll post that video in the show notes so you guys can get a visual of that. Let's talk healthy footwear. Why does healthy footwear matter, and what does it look like?
Well, we could do a whole podcast on just this, but
I'm sure we will.
Healthy footwear allows your foot to be a foot. And that sounds so basic, but most of our footwear that is popular in our culture does not allow a foot to be a foot. So a foot should be able to splay all of its toes. So all 5 of the toes should be able to splay outwards, which means a shoe needs to be wide enough or have a wide enough toe box that allows those toes to splay outward. That also allows the big toe to go through its full range of motion, just like we talked about. When you have a really narrow toe box, think pointy dress shoes or high heels, something that's squishing your toes all together. It doesn't allow the toes to be toes. It doesn't allow the big toe to push through its full extension, and that creates a lot of weakness through the muscles of the arch. Your shoe should also allow your foot to be mobile. So some shoes create a lot of rigidity. So they don't allow your foot to be flexible through its range of motion. They don't allow your foot to go side to side. Our feet, when we're on uneven surfaces, are the ones that allow us to walk over, dirt or rocks or whatever it is. Our feet have to be mobile to what they're walking on. So if we're in a really rigid shoe, that shoe is not going to allow that foot to move how it should. And then the last is having the shoe should be flat or not have a heel hike. That doesn't mean it can't have some cushion, because sometimes we need a little bit more protection from our hard surfaces that we walk on all the time, like concrete and cement. But when we put our foot into a forward position with a heel hike, it puts more load up into our knees, into our hips. And so our feet were designed to be flat on the ground. And so when we force our foot into a non-natural position, there's going to be compensations and dysfunctions that end up happening.
Yeah, and so the term that is common in the footwear industry is zero drop.
Yeah. Or minimal drop. Sometimes it's 3 millimeters or 4 millimeters, but minimal discrepancy between the height of the toes and the height of the heel.
Yep. Let's talk about the insole test, because some people think that they're wearing shoes that are wide enough, and when we actually evaluate that, they're not. Can you talk about the insole test?
The insole test is when you take out your insole of your shoe and you put it flat on the floor, and then you put your heel and your foot on it and splay your toes as wide as you possibly can. Now, some people may not even be able to splay their toes because they're really smushed together. But if you picture your big toe in line with the backside of your heel, fully outsplayed, your insole should be big enough to keep your toes in your shoe. But if your toes are going off the sides of your insole, then that shoe is not wide enough.
Yeah, if you put your foot on that insole and your toes are hanging off the outside of that insole, that means that it is not a wide enough toe box
Yeah.
for you. If you have to cram your toes in order to get them on that insole, that's what's happening inside your foot, even if you can't see it.
And if your shoes are cute, the cuteness is not worth your foot health. Your foot health is worth more than the cuteness of your shoe.
So we'll add in the show notes a few websites where you can find some great healthy footwear that is also cute.
Totally. You can have both. Both can exist together. And I think, too, if you're struggling with foot pain, seeking help on getting mobile, stable, and strong while you also find healthy footwear, because changing your shoes can impact your pain, definitely, but it's not the whole picture. And so I just encourage you to seek more solutions than just footwear and fixing that foot pain.
So how does having a rigid ankle and weak calves negatively impact the knee?
So it's really similar to the big toe. You need full mobility of your ankle to walk through your gait cycle. And so if you don't have that, there's going to be compensation that your knee ends up doing that it shouldn't. And so the strength of your calves also dictates the tightness of your calves, right? So weak muscles tend to be really, really tight muscles. And so when you have a tight calf, it's pulling on the posterior side of that knee and again creates misalignments in that knee, which then increases degeneration.
Yeah, and whenever a joint won't move as far as it's supposed to, the joints above and below it pick up extra movement, are forced to do extra movement. And so mechanically, when the ankle won't go through its full range of motion, the foot will turn out, and that'll cause a misalignment in the knee to accommodate for that lack of ankle motion. So let's talk lifestyle practice. Elevated calf raises. So standing on a step near a wall, letting both feet drop down that step, and then pressing up. Doing that for 3 sets of 30, 3 sets of 40. You can move to single leg. Depending on your lifestyle, you'll have different strength requirements, but the nice thing about the elevated calf raise as a tool for ankle mobility and calf strength is that it gives you both. And so it'll fix both of those problems with one exercise. And again, we will put a link to an explainer video for that exercise in the show notes.
Yeah, and I feel like with calf raises, doing them barefoot, because you also want to doing them barefoot because you also want to strengthen your arches. And so when you have shoes on, that limits the amount that your arch can turn on and fire because it's shoved into a shoe. And so taking your shoes off, putting some toe spacers on, and doing calf raises, pushing through your big toe, making sure your arch is turning on, as well as your calves through that movement, is going to exponentially increase its benefit even more.
Yep. Let's go down to the fourth major variable and risk factor, joint load dosage. This one has a really interesting piece of research behind it. There were some researchers who set out to prove that running was bad for your knees, and it caused osteoarthritis in the knee and broke down cartilage at a rapid rate. And so they designed the experiment to have a control group who was sedentary or not running, a group of people who was running but was doing a moderate amount of mileage, increasing their mileage 5% per week, and then there were more an aggressive protocol of runners. And what they were expecting to find was the sedentary group would lose the least amount of cartilage. The moderate protocol group of runners would show a moderate loss of cartilage, and the aggressive protocol of runners would have aggressive loss of cartilage, have the most cartilage loss. So they were expecting a linear result out of this study. And the findings were fascinating. The people that had the highest amount of cartilage loss in the study was the sedentary group. Then the group that had the second highest amount of cartilage loss was the aggressive protocol runners. And then the third group, the moderate mileage protocol runners, actually grew cartilage. They actually had denser and thicker cartilage at the end of the study. And this really confounded what the popular notion around running being bad for your knees. It really confounded that. And I think what we can take away from that and what we can learn from that is that load dosage matters. How much load and stress and work we put through our joints really matters. And a sedentary lifestyle is the worst thing that you can do for joint longevity. The second worst thing you can do is go out and just push really hard all the time, recklessly loading your joints without an intelligent protocol or application of load. And the sweet spot is really applying load to your joints regularly, such as running, walking, lifting weights, but doing so in a moderate fashion and increasing that load 5 to 10% per week, just a little bit per week. You can do the math if you want to and get technical. I don't know that that's necessary for most people, but increasing load 5 to 10% per week is the best way to regrow cartilage and the best way to prevent that cartilage loss. And the research is very clear. It's not sedentary lifestyle. It's not pushing hard. You have to find that sweet spot.
Well, it just goes to intelligent exercise prescription, right? Yeah. If you're sedentary, you're going to get really, really weak, and that's not going to support your body. And if you overdo, your body's not going to be strong enough for the amount that you're doing. And so intelligent exercise prescription just looks like slowly overloading your muscles and your joints to where they get stronger, they get better, they get more healthy, but you're not sitting on the extremes to either end.
Yep. So does that mean we can definitively say that running is not bad for your knees?
In moderation, right?
There's so many variables there, right? It's like, well, do you have misalignments in the knee? If you have misalignments in the knee, you probably shouldn't be out there running on them. So
it's just a bad question to begin with.
It is. It really is. And I think that's kind of what I wanted to highlight. It's nothing is quite as simple as, is this activity good or bad for your knees, especially something as complex as running. Mm-hmm. It doesn't have to be bad for your knees. Okay, let's talk body weight. Let's start with a stat here. Obesity increases women's risk of knee osteoarthritis by 400% and men's by 500%. And so it's very clear that obesity is really hard on the knees. And so this is not a new piece of information. We aren't adding anything to the cultural dialogue here. And so I don't know that we need to spend a lot of time on this topic, but I think calling it out as one of the 5 major risk factors and needing to be aware of it as a risk factor for preventing knee replacements is important. What lifestyle practices do we often recommend for people to maintain a healthy body weight?
I mean, first of all, I think obesity causing an increased risk for osteoarthritis is very multifactorial, right? It's the weight itself, but then how that weight translates to how strong somebody can be. And oftentimes when people weigh more, they move less, and then they gain more weight, and then they move less, and then their muscle tissue gets weaker, and then their joints get weaker. And so all of those biomechanical things partner with somebody's weight and how well they can take care of their knee. So specifically when it comes to lifestyle practices for maintaining body weight, maintaining a proper caloric intake, and data is the most important thing when it comes to that. So logging your food. Sometimes people think they're eating healthy. Sometimes people think they're not eating healthy. write it down so that you have concrete data to make decisions by. If you're doing it off of what you remember, do you remember what you had for lunch 2 days ago? Because I don't. And so having the data to make scientific, concrete decisions when it comes to food is really, really important. And then maintaining cardio, having 90 to 200 minutes in the zone 2 cardio per week. And what that looks like is 30 minutes a day, 3 to 7 days per week. Zone 2 is when you're breathing heavy, but you could still talk to somebody. So it's not you have to go out and do sprints or you have to go out and do this really intense HIIT workout. It's just get out there and move your body and increase your heart rate and allow your metabolism to respond to that.
Yeah, and I think the last lifestyle practice that is crucial for maintaining a healthy body weight is taking care of your hormones. Getting a complete hormone panel done annually, or definitely if you're making concerted attempts at reducing your body weight and it's just not working, just don't leave off the hormone component of that. Get an annual hormone panel done and correct any imbalances.
I also think that struggling with body weight is very emotional and mentally taxing. And so if this is something that someone has struggled with for a really long time and it's not a simple fix, bringing on like a hormone panel, but a nutritionist and also a counselor, and having someone work with you through the mental and emotional side of food, because it's definitely a mental and emotional aspect of the human life. And so I would also just encourage that regard of maintaining emotional and mental health as well.
Great. I think that wraps our conversation on preventing knee replacements. Thanks for coming and talking with me.
Great. Thanks for having me here.
And just as a reminder for people who are watching this, we have extensive resources and citations in the show notes. So if you are wondering what an outer thigh raise is or a big toe mobilization is, check out the show notes. We have a lot of resources there for people. Thank you for watching the Joint Pain Podcast. I'm Matthew Lister, and if you want help walking through your chronic pain journey, you can find more information at experiencealign.com.